Let's talk about that patient you bring up though, Bob. That liver mets, you know, the multiple organs involved. Patients maybe now that we've seen after surgery and they've got progression on their next scan. Now we're thinking more systemic therapies,
Yeah.
but the fields are changing. Nick, where are we today with systemic therapy in the frontline setting?
Well, you know, it was a pretty dismal field for a long time. I mean, you're
I'm old enough to know.
You're old enough to remember. We didn't have much except interferon and occasional interleukin-2, and when we got sorafenib and sunitinib and temsirolimus later, we were like, whoa, this is great. I wrote this editorial, An Embarrassment of Riches, because we had 3 drugs. You know, I've got to redo the editorial now that we've got 10 or 12. It does give us a historical perspective, but remember that the 2 go-to drugs, sunitinib and pazopanib, really did change the field. Mm-hmm. I mean, you know, we've all written papers about whether it's better to give sunitinib or whether to give pazopanib. They were comparable drugs. Maybe for certain subsegments, pazopanib is better than the sunitinib, and maybe it's better to give a different sunitinib schedule. And, you know, we can go down the line and try to find out the very refined, best first-line TKI. But darn, those are good drugs. They're good drugs. I reminded me of a story. I had a prisoner come in shackles the other day with belly pain, and he said, well, he's got this thing in his abdomen, and I went, whoops, it's like 25-centimeter mass. Wow. The guy, he could barely sit up. And I went out and I got a sample of one of the TKIs, and I said, take this today. And within 24 hours, his pain was gone. He was back in 3 weeks, and he said, I don't know what you gave me, but it was great. You know, so you can't underestimate the power of an active TKI. Now, I'm not going to turn around and give a guy like that immunotherapy until I know what I'm dealing with. But we've come a long way, baby, and it's good to be where we are.
It sure is. It sure is. I mean, I think that's a great perspective, and you know, I share with you some of the early days and the frustrations, and you know, now we struggle with toxicity and how do we maintain these patients on dose? But look, that's a good problem to have. Right. When you have patients responding to therapy, and our biggest issue is how do we keep them on drugs? That's a good problem. We didn't have those problems before these drugs, so it's a good perspective. But now we have some newer drugs, and cabozantinib now recently had a label expansion based upon some phase 2 data in the frontline setting. Brad, you want to tell us about that?
Yeah, absolutely. So I mean, based on the phase 3 data with cabozantinib showing a OS survival benefit versus everolimus in the second-line setting with an acceptable safety profile toxicity, Tony Schreier worked with Alliance to do a randomized phase 2 looking at cabozantinib at the standard 60 milligram dose versus sunitinib. You know, that was the 4 weeks on, 2 weeks off schedule, and it was designed to show that cabozantinib was superior to sunitinib. And so they randomized close to 160 patients. Interestingly to note, these patients were intermediate and poor risk by IMDC criteria. Over 10% of them were PS of 2, and over 30% of them had bone mets. So these were sicker patients. And at the end of the day, after extensive independent review and investigator test review, I mean, the data sort of held up that there was about a 3-month improvement in progression-free survival with cabozantinib when compared to sunitinib in these patients. Now, there's been arguments that the progression-free survival of 5 to 6 months in the sunitinib arm is lower than what we've seen in historical controls, but all the older studies really had more favorable risk patients, and so looking at some of the data, that number seems to be realistic. So based on this improvement in progression-free survival, the FDA recently, an acceptable safety profile with comparable toxicity to sunitinib, if anything, less hematologic toxicity with cabozantinib, and while there's more grade 1 fatigue, less grade 3-4 fatigue with cabozantinib in the trial, the FDA actually granted approval to patients with metastatic renal cell carcinoma received cabozantinib frontline. Interesting enough, this was for all risk categories, so it was not limited to those with intermediate and poor risk disease.
Interesting.
So you've been using that?
So we have. I mean, I had a patient just a couple weeks ago who presented with bone-only metastases. And so we have data, obviously, from Scudier looking at the METEOR trial that, I mean, bone metastases are a poor prognostic factor. They tend to do poorly. Cabozantinib seems to have a better efficacy in these patients. I mean, they still do poorly, but I think it was like 7 versus 2 months in the METEOR trial with bone metastases, cabo versus everolimus. So yeah, so I had a patient, 56-year-old female, who only had bone-only metastases, and it was 2 days after the FDA approval for cabozantinib.
I'll put you up against my pazopanib lady with the same thing. She's doing great. So, you know, I'm going to be a little skeptical as to which TKI is better. Remember, we did compars, big study, sunitinib versus pazopanib, no difference. I think cabo got a little bit of a pass there. But it's good because I do like having options. And we're the ones who should be deciding that anyway. You know, we're the docs, and if we have a drug, if I wanted to use axitinib frontline, I wish I could in some patients. So I love the idea of having the option. I'm not sure it's been as rigorously tested as I would like, but, you know, this is the real world. We got a drug, so let's go with it.
I think we've seen data, and I remember talking to you about this almost 10 years ago when XL184 came out with the prostate cancer data and how impressed we were about its activity in the bone metastases. And I think we have extrapolated through that when it came down to now with Cabometyx. We believe that in patients who have bone involvement or significant bone involvements, we would think, I think reactively, that Cabometyx in that patient population would probably be better than the other TKIs that we use in first-line therapy. But I agree with you. I think this is still a learning curve that we have. I think all these therapies do show to us the tolerability is a significant issue. And I think that all of our patients are different.
Well, I like the mechanism. I mean, the MET inhibition, it may well be that the VEGF, the pure VEGF-driven tumors are probably a better prognosis, whereas the tumors that have already evolved out of VEGF to MET, I mean, we talked about this 20 years ago, that MET is the escape mechanism, and it may well be that a more advanced tumor is already upregulated MET, and you want to go for it at that point. So having the ability to talk to the patient about that is, I think, the most important thing. You can think it through and say, you know, you got 3 choices, first line. Let's go through what you like to do. And what are your comorbidities? What are your complication rates? How about your cardiovascular disease? You got GI disease. You've had inflammatory bowel disease. You know, what do you get to choose from here?
Right. Well, you know, I'm presenting at GU ASCO this weekend on the subgroup analysis from CABOSUN, and it's interesting, just the point you brought up about MET, because, you know, Tony Schwery looked at, you know, within this study, the MET expression in primary tumors from CABOSUN, and about half of them had high MET expression in their primary tumors, and that group of patients derived a much greater benefit associated with cabozantinib, really kind of, in my mind, validating this mechanism. It truly is a multi-targeted drug in that setting. Now, I'm not saying MET is a standard approach. Now, we're not really set up to go and stain our tumors like that clinically, but I think it's something that does need further follow-up for sure.